Good morning, everyone. I am Anna Virgil G. Quahao, and for today, I'll be discussing to you Chapter 23, the Mycobacteria. What is Mycobacteria? Mycobacteria are rod-shaped aerobic organisms that are acid-fast positive because of the complex nature of their cell walls that include mycolic acid. So when we talk about aerobic organism, these are organisms that can survive and grow in an oxygenated environment. It is also acid-fast because when stained by basic dyes, they cannot be decolorized by alcohol regardless of treatment with iodine. Mycobacteria grow more slowly than other bacteria. Both non-selective and selective media in solid and liquid forms are used to recover organisms from clinical material. It cannot be classified also as either gram-positive or gram-negative. And there are more than 200 Mycobacterium species, including many that are saprophytes. So as you can see on the screen, the table shows the list of mycobacteria that infect humans. So, sa first column, muna siya ang mga species, and then sa second is the reservoir, and then the third column is the common clinical manifestation and comments. So, I will not one by one read what is written in the table since this will be discussed sa upcoming slides. Mycobacterium tuberculosis. So, sa previous slide a while ago, this is under sa species sa Mycobacteria na always considered as pathogen. So, when we talk about pathogen, this is an organism that causes disease. So, unsa kaya nga disease ang ginakos sa Mycobacterium tuberculosis? This causes tuberculosis. Next, let's proceed with the morphology and the identification. First is the typical organism. In tissue, tubercle bacilli are thin, straight rods measuring about 0.4 times 3 micrometer. True tubercle bacilli are characterized by acid fastness, that is 95% ethyl alcohol containing 3% hydrochloric acid or acid alcohol quickly decolorized as all bacteria except the Mycobacteria. Next is Zell-Nielsen technique of staining is used for identification of acid-fast bacteria. So this method, dili na ko mo go deeper ani kay this will be furtherly discussed sa upcoming chapter. And then it can also be demonstrated by yellow-orange fluorescence after staining with fluorochrome stains. Examples are auramin and rhodamine. Culture. The media for primary culture of Mycobacteria should include a selective medium and a non-selective medium. Selective media contain antibiotics to prevent the overgrowth of contaminating bacteria and fungi. There are three general formulations that can be used for the non-selective and selective media, and these are semisynthetic agar media, unspesated egg media, and broth media. So for semisynthetic agar media, this is used for observing colony morphology, for susceptibility testing, and with added antibiotics as selective media. It is also less sensitive than other media. Inspissated egg media, on the other hand, contain defined salts, glycerol, and complex organic substances. Examples are fresh eggs or egg yolks, potato flour, and other ingredients in various combinations. With added antibiotics, graft and mycobactocell are used as selective media. And then broth media, this supports the proliferation of small inocula. For growth characteristics, the growth rate is much slower than that of most bacteria. The doubling time of tubercle bacilli is about 18 hours. For reaction to physical and chemical agents, more resistant to chemical agents than other bacteria because of the hydrophobic nature of the cell surface and their clump growth. Tubercle bacilli are resistant to drying and survive for long periods in dried sputum. For variation, occur in colony appearance, pigmentation, virulence, optimal growth temperature, and many other cellular or growth characteristics. And then for the pathogenicity of Mycobacteria, humans and guinea pigs are highly susceptible to M. tuberculosis infection, but fowl and cattle are resistant. M. tuberculosis and Mycobacterium bovis are equally pathogenic for humans. Route of infection, respiratory versus intestinal, determines the pattern of lesions. So, constituent of tubercle bacilli. The constituents listed below are found mainly in cell walls. Mycobacterial cell walls can induce delayed hypersensitivity and some resistance infection and can replace whole mycobacterial cells. This content is only elicit delayed hypersensitivity reaction and previously sensitized animals. The first one is lipids. Mycobacteria are rich in lipids. Lipids are to some extent responsible for acid fastness. Then proteins. Mycobacterium contains proteins that elicit the tuberculin reaction. They also elicit the formation of variety of antibodies. And then polysaccharides, their role in pathogenesis reaction of disease is uncertain. Induce the immediate type of hypersensitivity and can serve as antigens in reactions with sera of infected person. For pathology, so we have here two principles of lesion, spread of organism in the host and intracellular site of growth. For two principles of lesion, naatay exudative type and productive type. Exudative type, this consists of an acute inflammatory reaction with edema fluid, polymorphonuclear leukocyte, and later monocyte around the tubercle bacilli. While productive type, when fully developed, this lesion a chronic granulomatous of three zones, a central area of large, multinucleated giant cells containing tubercle bacilli, a main zone of pale epithelioid cells, often arranged radially, and then a peripheral zone of fibroblasts, lymphocyte, and monocyte. Spread of organism in the host. Tubercle bacilli spread in the host by direct extension through the lymphatic channels and bloodstream and via the bronchi and gastrointestinal tract. And then intracellular site of growth. They reside principally intracellularly in monocytes, reticuloendothelial cells, and giant cells. Primary infection and reactivation types of tuberculosis. When a host has first contact with tubercle bacilli, the following features are usually observed. 1. An acute exudative lesion develops and rapidly spreads to the lymphatics and regional lymph nodes. The exudative lesion in tissue often heals rapidly. 2. The lymph node undergoes massive cessation, which usually calcifies, gone lesion. And then 3. The tuberculin test result becomes positive. Immunity and hypersensitivity. During the first infection with tubercle bacilli, a certain resistance is acquired, and there is an increased capacity to localize tubercle bacilli, retard their multiplication, limit their spread, and reduce lymphatic dissemination. This can be attributed to the development of cellular immunity, with evident ability of mononuclear phagocytes to limit the multiplication of ingested organisms and even to destroy them. Clinical findings. Tubercle bacillus can involve every organ system. Its clinical manifestations are protein. Fatigue, weakness, weight loss, fever, and night sweats may be a sign of tuberculous disease. Pulmonary involvement giving rise to chronic cough and spitting of blood usually is associated with far advanced lesions. Meningitis or urinary tract involvement can occur in the absence of other signs of tuberculosis. And then bloodstream dissemination leads to miliary tuberculosis with lesion in many organs and a high mortality rate. Diagnostic laboratory test. A positive tuberculin test result does not prove the presence of active disease caused by tubercle bacilli. Isolation of tubercle bacilli provides such proof. Specimens consist of fresh sputum, gastric washing, urine, pleural fluid, joint fluid, cerebrospinal fluid, biopsy material, blood, and other suspective material. For the contamination and concentration of specimen from sputum and other non-sterile sites should be liquefied with N-acetyl L-cysteine, the contaminated with sodium hydroxide, which kills many other bacteria and fungi. It also relies with buffer and concentrated by centrifugation. Smears. Sputum, exudate, or other materials is examined for acid-fast bacilli by staining. Culture identification and susceptibility testing. Process specimens from non-sterile sites and centrifuge specimen from sterile sites. Can be cultured directly on the selective and non-selective media. This selective media broth culture often is the most sensitive method and provides result most rapidly. A selective agar media should be inoculated and parallel with broth media cultures. DNA detection. Polymerase chain reaction or PCR holds great promise for the rapid and direct detection of M. tuberculosis in clinical specimens. The overall sensitivity is 55 to 90% with a specificity of about 99%. So as you can see on your screen, the table shows the Runyon classification of Mycobacteria. So it is called traditional Runyon classification of Mycobacteria because it is based on the rate of growth, production of yellow pigment, and whether this pigment was produced in the dark or only after exposure to light. So Runyon Shakai, it was introduced by Ernest Runyon in 1959. Treatment. Chemotherapy, primary treatment for mycobacterial infection. The two major drugs used to treat tuberculosis are INH and RMP. INH is isoniazid, or also known as isonicotinic acid hydrozide, an antibiotic used for treatment of tuberculosis, and RMP is rifampin, one of the antibiotic medicine used to treat tuberculosis also. First-line drugs are pyrazinamide, PZA, ethambutol, EMB, and streptomycin. So when we talk about first-line drug, muna siya ang mga drugs na first choice for treating tuberculosis and consider siya as an effective treatment and then least causing of side effects. Second-line drugs are more toxic and less effective, or both. They should be used in therapy only under extenuating circumstances, example, treatment failure, multiple drug resistance, which include kanamycin, capreomycin, ethionamide, cycloserine, ofloxacin, and ciprofloxacin. Epidemiology. The most frequent source of infection is humans who excrete, particularly from the respiratory tract, large numbers of tubercle bacilli. Close contact, example in the family, and massive exposure, examples in medical personnel, make transmission by droplet nuclei most likely. For tuberculin negative people, the risk of acquiring tubercle bacilli depends on exposure to sources of infectious bacilli, principally sputum positive patients. Next is infection occurs at an earlier age in urban than in rural population. Prevention and control. Prompt and effective treatment of patients with active tuberculosis and careful follow-up of their contacts with tuberculin tests, radiographs, and appropriate treatment are the mainstays of public health tuberculosis control. Drug treatment of asymptomatic tuberculin-positive persons in the age groups most prone to develop complications, examples are children, and in tuberculin-positive people who must receive immunosuppressive drugs, greatly reduces reactivation of infection. Non-specific factors may reduce also host resistance. thus favoring the conversion of asymptomatic infection into disease. Such factors include starvation, gastrectomy, and suppression of cellular immunity by drugs. Examples: corticosteroids or infection. HIV infection is a major risk factor for tuberculosis. And then virus leaving a virulent tubercle bacilli, particularly BCG, and attenuated bovine organism, have been used to induce a certain amount of resistance in those heavily exposed to infection. Vaccination with this organism is a substitute for primary infection with virulent tubercle bacilli without the danger inherent in the latter. The available vaccines are inadequate from many technical and biological standpoints. Nevertheless, BCG is given to children in many countries. Statistical evidence indicates that an increased resistance for a limited period follows BCG vaccination. And lastly, eradication of tuberculosis in cattle and pasteurization of milk have greatly reduced M. bovis infection. Now let's proceed for the concept check. So Mycobacteria are rod-shaped. They are also aerobic organism. They grow more slowly than other bacteria. And then more than 200 species of Mycobacteria. And then granulomas are hallmark of infection of M. tuberculosis complex. And humans acquire tuberculosis from inhaling or from inhalation of infective droplet of nuclei. Then tuberculin scan test or IGRAs used to screen person for tuberculosis infection, and lastly requires acid-fast smear for and culture. That's all. Thank you. Thanks for listening. And that concludes my discussion today. And for the continuation for the discussion of other subtopics under this chapter, it will be discussed to you by Miss Samantha.